for bearing with us here. As I was saying, I'm State Senator Scott Bennett of the 52nd District, representing Champaign-Urbana and parts of Champaign-Vermilion counties. Tonight is intended to be a Phase 4 virtual town hall where we're going to pick up where we left off at the beginning of the pandemic with a panel discussion, including tonight we have Pryde here to my front left. She's the Champaign-Urbana Public Health District Director. We have Dr. Jokela with the University of Illinois College of Medicine and an expert in epidemiology. We have Dr. Robert Healy with Carle in adult medicine here at the University of Illinois. And we have Mike DeLorenzo with the University of Illinois. I would point out that we are in two tiers. I don't know if that's obvious here on the camera, but we are all social distancing and of course had our masks when we entered the space. What I think we should do first, I guess, is just I'd like to kind of start out by asking Julie, as the Public Health Director, the most obvious thing that we've seen since we started here so months ago is dining, is eating out. So can you talk a little bit about when restaurants are expected to open for inside dining, and how does maintaining distance improve the odds of not passing along COVID to other diners?
Okay. Okay. So we've been doing a lot of outdoor dining, and that has been very successful in Champaign County. But starting tomorrow, there will be the availability to have some indoor dining with limited seating capability. With COVID transmission, it's all about trying to maintain distance from one another, and so distance and time is what you're concerned about. So with the restaurants, you're in there for a longer time, so they want to make sure, you want to make sure that the tables are far enough apart. We urge people to be very kind with the restaurants and the businesses as they're reopening, because things are going to be different and everybody's going to need to get through this and learn the new ropes of it. But again, I think that a lot of the outdoor dining will probably continue because people seem to really like it. We've gotten lots and lots and lots of compliments about how they're doing it in Champaign County. So starting tomorrow, they'll be able to go in, again, wear a mask. The waiters and the staff inside the restaurant should have masks on as well. And then once you get to your table, you're going to be urged to remain seated, and obviously you'll be able to take your mask off at that time.
Thank you so much. Dr. Jokela, obviously dining is one issue, but so are grocery stores. So I know that many of our retail establishments here have provided either carry-out curbside service or even grocery delivery. But many people that have called our office have been concerned that the packaging of the groceries when they come in, or even the curbside food they get from restaurants, still present a real risk. Can you talk a little bit about, if I have groceries delivered to my house, or if I go out and pick it up and bring it home, what, if any, risk does the packaging itself pose to me and my family?
Thank you, Senator Bennett, and it's a great question, an important one, I think, for all of us. Unlike where we were okay, hear me okay? Excellent. Unlike where we were a couple months ago, there's a little bit more known now than there was then, certainly in terms of the virus surviving or persisting on surfaces, if you will, and that's, I think, what we're getting at with the packaging of food and all that sort of thing. So long story short, I think there's much less concern now that that's a real threat compared to what we thought a couple months ago, and it's just not it's just not thought to be as big of a concern, if any concern, actually, relative to where we were a few months ago. So we're grateful that we know a lot more now, and I think The primary things, again, are social distancing and wearing face masks when we're out in public, and, that pertains to how we shop for groceries, if people are actually going into the grocery stores, but the actual packaging in that is much less of a worry than it used to be, so, thank you.
I appreciate that. Dr. Healy, I'd like to talk a little bit about masks. A lot of the questions we've already received involve what masks people should be wearing when they do wear masks, and I think a lot of people recognize they've heard this phrase, the N95 masks, and my understanding is that American manufacturers and certain international manufacturers call the same standard different things. But what I've heard from a lot of people is that you don't want to get these masks because we should allow that to go to health professionals, and so we should rely for our own limited exposure on homemade masks or on non-medical grade masks. Can you talk a little bit about what you've seen, at least at Carle, what is available to medical professionals right now, and what opinion do you have about what masks people in the general public should be wearing?
Well, thanks, Dr. Bennett. Those are great questions. I think, so you're correct that N95s are medical grade masks. They are made so that virus particles don't transfer through the mask very well. And in the medical profession, or wherever you're using these, you have to actually test it and train on how to use the N95 mask, because you have to have the proper seal. We do testing at Carle as well as other places do to make sure that we are wearing them correctly, our face size and shape is correct for the N95. So they're really not something just for the general public, and not for any other reason than they're really helpful in preventing the virus from spreading in a high virus environment, like a hospital room with a known patient, but they're not needed in everyday life, and you need to be trained to wear them.
This kind of follow-up question to that is to anyone that wants to answer on the panel. I've seen many people on Facebook write about going into restaurants, and I also have seen in the community people that are wearing masks, but are not wearing it in a way that covers both their mouth and their nose. So either they wear it below their nose, or they wear it sometimes even, I'm going to guess you're not going to recommend only one lip is shown. But the nose part of it, are we worried about exposure through the nose? And should masks, if properly worn, be covering both the mouth and the nose? To anyone that would like to respond.
Sure, Senator Bennett, I'd be happy to take that one. It's a great question. It's a really important question, and the answer is absolutely. The mask must cover the nose and the mouth both. It really doesn't work if only the mouth is covered. I don't think I've seen people wearing only over the nose, but that aside, it requires both, and it's just really important. Essentially, if it only covers the mouth and not the nose, it's it's no better than not wearing it at all. So hope that answers the question.
If I could, and I could talk more about different types of masks as well, but Dr. Jokela is exactly right. You got to cover your mouth and your nose. One thing that we should talk about is what other types of masks are there. There's surgical masks, which I have here, that we use in the hospital all the time for surgeries, etc. We're used to them over the years. We do recommend, we've made a change this actually just this week at Carle. We are recommending that people wear surgical masks all the time. That is, employees who are going to be taking care of patients, or staff rather. Then there's the homemade masks or the cloth masks, and those are great for everyone else. Someone who's not taking direct care of a patient that works at Carle, we're going to recommend they wear a cloth mask. Anybody in the community wearing a cloth mask that covers both your mouth and your nose is the way to go.
Very good. Well, I realize now I'm being flanked by representatives of the two largest employers in Champaign County, Carle, of course, and the University of Illinois with Mike DeLorenzo. Mike, can you talk a little bit about, obviously, here we are in middle of June, a lot of people are wondering, what is Champaign-Urbana going to look like in just a couple months? Are we going to expect tens of thousands of students back on campus? What risk of any event, if any, does that pose? And how do you run a flagship university the size of University of Illinois while still maintaining social distancing? Can you tell us kind of what your current plans are and how you plan to respond?
Sure, thanks, Senator Bennett. And first, thanks on your advocacy in Springfield for the university for all the years. So we really appreciate your support. So we have a steering team and 7 working teams looking at all of that, everything from university life to classroom design to housing to dining to how we're going to do all of this. Certainly the students will be back. They're going to still be back in late August, as they always are. There's going to be a modified learning place or put in place where students will be in the classroom, face-to-face instruction. However, there will also be online. Obviously, we have to abide by the governor's phase 4, which will be 50 or less people in a space. And so what we're doing is going through all 300 plus of our classrooms right now and figuring out what our capacity is based on 6-foot social distancing. And then obviously our students will be wearing masks as well as employees. So housing is doing the same thing. Our dining program will be very limited seating, grab and go type things. There will be more singles than normal. We will have some doubles, but they're going through those spaces right now and determining the appropriate distancing. So it's a massive project. Obviously, the other thing we're going to do, and we've talked a lot about, is testing. We have a team called SHIELD that is working on a saliva-based test right now. They're doing pilot testing right now, and we'll ramp that up to faculty and staff in July. In August, when the students come back, and hopefully some type of staggered fashion we're still working on, all students will get tested when they get back to campus, and then they will be tested 4 days later. And then we will set aside 5% of our housing for any type of people that need to be quarantined. And then we will be using an app called Rockwire, which will allow us to determine flashpoints, if you will, or other areas of concern. And it will also notify students and faculty and staff when they should be getting tested. They'll be asking questionnaires about, kind of what you're doing, the types of things you're doing, and if you're in a higher risk category, you might get tested more often. So those are some exciting things. The testing is and maybe Dr. Jokela could talk about this, is a new type of testing, and we're getting a lot of calls from across the country about how we're going about doing this. We have some, it makes me proud to be part of the University of Illinois because we're able to do this and do it, in essence, in-house here for the safety of our faculty, staff, and students.
Be happy to tag on to that just a little bit, Mike. Yeah, it is really exciting, the testing that the university is planning for this fall when the students come back. It is new, and tests are underway to ensure that it's accurate and reliable and all of that, but certainly a saliva-based test would be much more palatable for people having done, as opposed to the deeper tickle-to-brain swab, as they say. So it is exciting, and I think absolutely there's a lot to be proud of with U of I pushing ahead in this direction and working on this. So it's good.
Well, we, as legislators, went to Springfield in May, and we were asked to get tested before and after. So I had 2 of the brain tickling tests. Tickling is the nicer way to say it. But I will say the staff at the drive-through Carle facilities that I went through were excellent, and it could have been worse. Let's talk about testing a little bit, Julie, if we could. Of course, the president has been in the news in the last week, saying that perhaps, or suggesting perhaps that this is having a negative effect, and I understand there's been some withdrawal of federal funding for testing from certain states. Can you talk a little bit about what changes are you seeing recently with government's response, whether it be federal or state, to testing, and where does Illinois stand in terms of how much testing they're doing now?
Okay, so Illinois is doing a lot better than a lot of states. Certainly, we've got a lot more state-sponsored testing, And certainly Champaign County is doing better than a lot of the other counties in Illinois, and that is directly thank you to University of Illinois and Carle, because what we have now, first of all, we have one of the community-based testing sites so that people can drive through, and it's a nasal swab, not the nasal pharyngeal swab, which actually does feel like it's going into the middle of your head, because it is. But so it's just a nasal swab, it's self-collected, and then what the exciting part is that it then goes, all the testing goes to Carle Lab, so we get the results back in 24 hours. And the point of all the testing is so that if we get a positive, public health can go in and do what it is that we do, which is isolate, contact trace, investigate, quarantine, and stop a spread that way. So there has been a lot of concern that we were going to lose our testing site because of the federal pullout. I don't believe our testing site out here was even federally funded. We are not going to lose it. I have been told that it will continue at least through January, and that we will also, they are going to expand. The National Guard will be pulling out of there, but there will be a private contractor coming in. So they are going to expand to have the walk-up testing as well. So since as soon as the labs ramped up, I mean, we've had really good access here to testing. So, you can get it at your healthcare provider. Carle has had the drive-through going forever now. Francis Nelson's doing testing. So there's lots of opportunities to get tested in our community. And certainly the community-based testing site is free. It's open to the public. It's 7 days a week, and it's from 8 to 4. So very convenient.
Julie, I think that's certainly been one of the struggles our community has had, our whole state has had. In this is they're early on, and when we met in our first town hall, there weren't enough tests. But I guess if there's any takeaway from tonight's town hall, if people are watching, we want to make sure that they know it certainly is available in our community right now. Do you have the information on the public health website? Is there a place they should go to if they didn't catch the times and the locations?
Yes, we have a COVID hotline at Champaign-Urbana Public Health District. It's 239-7877. Had to think about that. And our website is c-uphd.org. Lots of information on there, including stats, testing numbers, testing broken down by different demographics. And they can also go to send an email with just any general questions to coronavirus@c-uphd.org.
Okay. So the two issues we really had when we met the first time was certainly accessibility to tests, but also accuracy of tests. And this is for anyone that wants to talk about this. There were a lot of rumors about false positives or I guess false negatives. Either way, accuracy of the tests, even when people volunteer for them. Can we talk about how far we've come in the last 3 months? Should people have any sense of confidence in the results of the tests once they submit to them?
I'd be happy to take a stab at that one, Senator Bennett. Again, I think we're in a much better place today than where we were a few months ago. I think there is still concern about false negatives, okay? So if someone's really infected or, if someone's really infected and they have a test done, if it's early on in the infection, they still may not turn positive, or the test may not be positive. So that still is a concern. That being said, these are the best tests that we have, and we're going with what we have right now. So, whether it's the nasopharyngeal swab, the new saliva swabs, the nasal swabs, this is what we have, and we're going with it. So we are in a much better place now. There's still questions, but there's a lot of work being done all over the country and really all over the world on figuring this out even better.
So, if I could, thank you. So the testing, when someone's in the hospital and we have a high suspicion they could have COVID, we will do 2 tests if the first one comes back negative, just for that very reason, that sometimes the first one could be negative, but if the clinician feels it really could be positive, we do another test. I think testing is a wonderful subject. I think we We should have more testing. I think that there's, I have Julie correct me if I'm wrong, but I believe there's definitely room for more people to go to Marketplace and get tested. In our lab at Carle, there's more room for people to have testing, meaning that if we get test samples, we can run them on a daily basis. Some good news, because I've had both tests, the brain stimulation and the anterior test. We've switched to Carle to do the anterior nares test. So what that is, it's basically a Q-tip that you put in the front of your nose for 15 seconds on the right side, then 15 seconds on the left side, and then that's the test. A lot easier to tolerate. If someone is worried about that, about their friend who got the nasopharyngeal, the real deep one, they said it was horrible, worst day of their life, don't worry about that anymore. You can come get tested. And if you want to get tested and you're a Carle physician or a Carle patient, you can call our hotline at 902-6100. And we can talk you through, do you need to get tested or not, and if so, where to go.
And I want to talk about testing a little bit from a public health perspective. So if someone is positive and we follow up with them, we're going to put their case, so anyone who's exposed is going to go into quarantine for 14 days. During that time, they can test, but they will still be away from others. And so that the testing is useful then, but they're still going to be in quarantine. So the other thing that I want to mention is that with the testing, that the way it's done, we are, well, I'm getting off track here a little bit in my thought process, but we do the quarantine part of it so that I'm just trying to say that people are not out running around, but when you get a test, this is what I'm trying to get at, when you get a test, this does not, and it's negative, it does not necessarily mean that you're not positive. Like Dr. Jokela said, you could be pre-symptomatic yet, and you could not have enough to show up. And the other thing is, you can be truly positive, and then you can go an hour later and become positive by getting around someone. So in that sense, the testing is a useful tool for public health, but I've had people say to me, well, I'm positive, so I'm fine, or I'm negative, I'm sorry, I'm fine, I can go, run around and do things. And that's not the case. It is literally a point in time. So when you're tested, it just means that you're not positive at that time, or potentially not positive at that time.
And Julie, you've certainly, in my conversations with you, talked about that being, it's a snapshot in time. So when students come back, we can know when they walk on campus where they are, but of course, we don't know what happens in the future. So let's talk a little bit about antibody tests. I know that's something we've heard rumors about, had some issues with accuracy and certainly availability, but for herd mentality to work, I guess, if it does, the assumption has to be if I get COVID, I can't get it a second time. So if I test positive for it, even if I don't have it today, but I had it a month ago, am I good to stop wearing this mask and go about my life? Can we talk a little bit about what are we knowing 3 months later? Can people get it a second time? And what is the latest with the antibody test?
So I think I'll talk, and then Janet can add, because she has special knowledge about the epidemiology of all this. What I would say is that the antibody test right now, for all intents and purposes, tells you nothing. And what I mean by that is, if you were to get an antibody test and it was positive, that means you were probably exposed, or you were exposed to the virus that causes COVID-19. But we can't yet say with any degree of accuracy that that means you're protected in the future. We're still too early on in the course of this disease. It's just from the end of December or maybe November, but not very long that we've had this. We don't know if you have antibodies, if it means you're immune, and if you're immune, how long might that last? We hope to find that out over the next several months, but we don't know that right yet. So I wouldn't change the wearing a mask. I wouldn't change being concerned about being within 6 feet of somebody. I'd still social distance, etc.
Sure, thank you. We'll hop in here too. Great points, and I agree with everything that Dr. Healy was just saying. There's just so much that we still don't know yet about antibody testing. So absolutely, regardless what the results of an individual's antibody test shows, it's critically important that social distancing, keeping at least 6 feet away from others, that's critically important, as well as wearing masks. Those things are absolutely critical, independent of whatever the antibody test shows. So that being said, there's a lot of work on trying to better understand these antibody tests and what they mean and the long-term implications. As Dr. Healy said, we don't know that yet, exactly what that means. If someone has a positive antibody test, we cannot say at this point that someone's protected and that, they're safe and they can't get it again. We don't know that yet. I do think it's really important as a public health tool and an epidemiologic tool to do antibody tests just to get a better sense of what's going on in our community. So I know there are some avenues to get antibody tests done. And I do think from a community point of view, it is important to gather that information so we get a better sense of what's been going on and what's currently going on in our community, even, despite all their shortcomings. So.
If I could, testing, how many of us have been exposed to this virus? And the serology can help us learn that. At Carle, we do run the serology test, the antibody test, and we've made it available to our staff and our physicians, et cetera, all the members of the healthcare team and the whole of Carle. And we've had a couple thousand people get tested in our system, and the amount of positivity is under 2%, 1.7, 1.8%, which I think was surprising to us. We thought it'd be a lot higher. In a way, it made me feel good because even people in the emergency department, in the ICU, taking care of the sickest COVID patients were protected. And I think that's because they're so diligent in wearing the appropriate PPE and trying, washing hands. All our hands are raw, everyone's is. So low level of antibody in the whole universe at Carle, and I think that's probably representative of our community because, as you say, we're one of the top employees in the county, so there's probably a lot of people out there that if there was a lot higher antibody levels than others, we probably would have seen that. So I think good news that our antibody level is low, but as you mentioned, Senator Bennett, the herd immunity, for us to feel comfortable that we've all been exposed enough that we hopefully will have some protection, we're a long way from that.
Mike, excuse me. Obviously, we're very proud the University of Illinois is an international university. It attracts students from all over the world and certainly all over the country. Have any steps been discussed to limit travel, or is there a way to discourage travel, and not just to international, to other countries, but to other states around the nation that are experiencing hot spots? Texas, Florida come to mind. Is there a way to do that, and is that something you're considering?
Yeah, so actually we were really ramping back on travel, period, because we're just still ramping the university back up, but also aside, because of some of the budget issues, we have asked folks to really ramp back on travel. What we're doing right now is following the CDC guidelines, which if anybody is coming in from overseas, they need to self-quarantine for 14 days. One thing we've learned through all of this is this changes almost daily, as you've seen in some of the hotspots in some of the other states. Other states are now restricting travel in or making those folks self-quarantine. So whether Illinois gets to that point, I don't know, but we will certainly respond to that. But we are asking anybody that comes in from overseas to self-quarantine for 14 days. But other than that, nothing yet.
Part of the plan for having this tonight is that tomorrow we move to the next phase in the state of Illinois, and that being phase 4. Julie, can you talk a little bit about what should people expect? What's the difference between phase 3 and phase 4, and how will they see that in their everyday life?
I think that probably the biggest noticeable thing will be that all outdoor activities, all outdoor recreation will be the same, and some limited capacity things will also be open, like movie theaters will be open with drastically reduced seating. Restaurants will have some in-person reduced dining. But some places are still not going to be open, and that has to do with them being a little more dangerous. Like trampoline parks will not be open, they're inside. Indoor playgrounds will still not be open because that they've been determined to be more dangerous. But a lot of things are going to be done, they're just going to be done differently. And we have to get used to this new way of doing things and trying to do things safer. And again, the main thing is to have social distancing and masks on, especially when you're inside of a building. And that's going to continue pretty much until the pandemic's over, or until we have a vaccine, or until the pandemic's over. So that's pretty much where we're going to be at.
One of the most publicized changes is gatherings. In phase 3, it was, I believe, 10 people. That was permissible. Under phase 4, after tomorrow, it'll be groups of 50. But I think it was one of the earlier briefings I was in when a state public health person was talking about. But you need to remember, it's pretty much 10 people cumulatively is the smart way to go. It shouldn't be 10 people today and then a different group of 10 tomorrow, and because that obviously exponentially ups your exposure. Pick the 10 people or now 50 people in your life that you miss the most and find a way to rotate them in. Would you agree with that? That was probably 2 months ago, or is that kind of outdated information?
Well, I'll answer that. As far as I'm concerned, and you have your household cohort or your cohort, those are the people that you can be around. But essentially, any person that you have contact with where you're not wearing a mask and you're within 6 feet, you risk exposure, you risk infection. And that is the case. The deal with 50, and again, it's not supposed to be 50 people back to normal, together. If it's an event or something where there's 50 people and it's inside, you still need the social distancing, you still need the masking, because we just recently had an example of an indoor event with, roughly 50 people, masks not being worn, and it caused an outbreak that then, keeps rippling through communities. So that can happen anywhere. So I think that there is some confusion, and I do worry about that because I do think people are getting the sense that, oh, well, if we can have 50 people together, then, we can do whatever. But that's not even the case. Even if you are out with a friend and you're at a restaurant or whatever, you absolutely are risking exposure if you are within 6 feet of that person.
If you were going in, and this is for anyone, if you're going into a restaurant, if you're going into a business, a movie theater, all the things that are opening up under phase 4, what are things you're looking at to know whether or not it's safe for you and your family? I've seen places where they encourage masks, where they are taking temperatures. That's something I see a lot. Is there really anything to that, or is that more kind of peace of mind for customers coming in?
The main things, again, going in any building is going to be, if you cannot maintain 6 feet from people, you need to have a mask on at all times. And that's just going to be, moving forward. The temperature taking can catch someone if they happen to have a fever at the time, but of course, a Tylenol can pretty much thwart that attempt at detection, whether it's inadvertent or intentional. And the other thing is, not everyone who gets this has a fever. So people need to still be really aware of the fact that the virus is out there. It's we're having community transmission. None of that has changed. Just because things are opening doesn't mean that suddenly everything is safer. That's not what that means. What that means is hopefully people are more used to doing the things that they need to prevent infection, and we can be safer moving forward.
Dr. Healy, obviously, the way that Illinois is structured, I think really the way the whole nation is supposed to be structured, is that you're looking at data and then removing restrictions based on that data. So we're in different regions here in the state of Illinois, for example, based on healthcare, medical care. Do you readily share certain information with other hospitals in the state, and are you aware of what their numbers are, so that you can also kind of see how we compare?
Yeah, good question. We do. We share on a daily basis. We share the number of hospital beds, the number of people in our hospital, the number of people in our ICU beds, the number of ventilators that we have available. That's all reported into public health. And we're able to see, in not only in our region, which is Region 6, for instance, or the broader area that is our Restore Illinois area, plus other hospitals, we can see what their data is like in that same system. So there's a lot of sharing of data. That's one thing, as I thought back to where we were 3 months ago, we had no data. We were really in a gray zone. We're still there, but we're getting better data right now.
Okay. Julie, just kind of take off of that, we're moving from 3 to 4. But if our region remains low, but other regions across the state have a spike like we've seen in some of the southern states, is there a scenario that you guys have discussed with public health where our region would remain in 4, but the others might be bumped down to 3?
Yeah, that's absolutely possible. And that's the reason why it's good to have the zones, because what you're looking at is, again, protecting the healthcare system so that you don't have people dying from other things because there's no capacity. So yes, that's how it's set up now. And they're even going to go to showing county-specific data, which I'm very excited about. I always like, the smaller the data, the more exciting. But so we're going to have that as well. And we keep a really close track on our county. But because Carle is so large and we have OSF, our catchment area, between the 2 hospitals, they see, I believe it's about 1.5 million people. So, Champaign can be doing a stellar job, but we have to worry about the entire catchment area as well. So it's when we see places, ignoring guidance and everything, that's concerning, because I think that Champaign County is doing a great job, but the people seem to be, we go out, we see lots and lots of mask wearing, but if that's not happening everywhere, it could still overwhelm the healthcare system. But if something happens where the southern part of the state, sees a massive spike, and our region, central region, is doing well, presumably they would go backwards and we wouldn't.
Dr. Jokela, I think that people's attention span can only maintain on one topic for a certain amount of time as well. But I look at my social media feed or conversations with my family, I certainly see it ebb and flow when it comes to COVID. And in part, I think in Illinois, it's because our numbers have gone down. Some people suggest that's related more to weather, that in warmer climates, it's harder to spread the virus. But isn't the fact that where we're seeing spikes in some of the warmer states, Florida, Texas, and others, doesn't that contradict that theory?
Absolutely, and it's a great point and a great question and an important observation. I think it is easy perhaps to get somewhat complacent about this, that, our numbers are going down, things are better, but the fact is it can come right back again very, very quickly. As we saw with the recent outbreak here locally within our county, but also exactly with what's being seen right now in Texas and Florida and some of these other states. So unfortunately, those states, they're hot, they're warm, and it's just proof that the virus can spread in those areas and those temperatures too.
But I do think that a lot of that has to do with no mask wearing, because your breath is liquid, it's humid out, your water molecules in your breath are going to attach to the humid air and fall faster. And I think we can see from a lot of outdoor events, including protests and things that we've had in Illinois, and certainly in Champaign-Urbana, there was extensive mask wearing. And we did not see cases arise from that. And I had assumed because of not enough social distancing that we might, but the combination of being outside and wearing the mask in those groups made a huge difference. I'm concerned when places we start going back and winter gets here and everybody spends more time inside. I'm concerned that if people don't wear the mask, that we're going to see more outbreaks.
It's a great point. It all gets back to, I think, human behavior in terms of our social distancing and the masks. And we know the masks do work, and that's the key going forward.
Mike, I want to talk a little bit about athletics, collegiate athletics. I know obviously it's a big part of people's lives in a college town, but also the economy of a college town when you have a Big Ten football game or the like. I have seen, I think it was in Asia where they had certain baseball or soccer with no one in the crowd, or with, I was at a church last night where the church had pictures of people, because it's got to be kind of awkward for a minister to speak to an empty sanctuary. But you can still get the TV revenue, I suppose, if you can find a way to play to an empty stadium. What conversations are we having at the university, and what would you expect at this point to see the college football season?
Yeah, so a lot of that's still being discussed with the Big Ten, but under our guidelines as Phase 4, we could have 20% capacity at the stadium for outdoor events. So that's roughly, for our stadium, 10 to 12,000 people. Obviously, they would have to be social distancing. They would be wearing masks. And concessions could be allowed, but there's a lot of protocols that need to be put in place, and all that is being looked at about whether we have different arrival times for ticket holders, so there isn't massing in certain areas, and there's ingress and egress areas are set aside. So all that's being looked at. I believe athletics actually is polling their season ticket holders, those that have bought tickets already, to see if they want to come back and they want to attend the games this year, or they want to apply it to next year. So all of that is happening, but we're proceeding as if for outdoor events that we would be at a 20% capacity for the stadium. Indoor events right now under the Phase 4 opening are not permitted, and so there's some discussion going on about whether the competition takes place without fans. So volleyball, hopefully we'll have other changes by the time basketball season gets here, but that's what we're operating under right now.
And certainly it would also depend on decisions made by other universities, because you've got to have somebody to play. And I know that these conversations are being made all over the place. So we've talked a little bit about how you wear a mask and the importance of wearing it over your mouth and your nose. But let's talk about, and this is for anyone, how long should you wear a mask? We have people that are, obviously masks are hard to get. I know we ordered some and they're back ordered at several of the places that we've looked. So certainly you can do the handmade or homemade rather masks. How often should you wash them? And are there special things you should do to make sure that you're not exposing yourself to the germs on the mask in your car or in your home?
I'd be happy to start and have colleagues chime in here. So absolutely, right, we talked about wearing them over the nose and the mouth, both. You got to be careful when you take it off, because you think, all right, so, any viral particles and things that could have contaminated the mask would be on the outside. And so when you take it off, just make sure you don't touch the front part of the mask. So just take that off, and then they should be laundered every evening, so every day is the ideal in terms of washing them and taking care of them in that way. In addition, I think it's important to remember with the masks, in general, what they're doing, especially the cloth masks, so we're talking about masks in the community now, they're protecting other people from any viruses or anything that we as the individual mask wearer may be spewing forth, all right, or breathing out. So it's really a commitment to our community and to others around us to try to protect those to try to protect everybody else. So the idea is to carefully put it on, behind your ears. When you take it off, don't touch it, and make sure you wash it every night. So welcome any other comments or input from colleagues.
Yeah, I agree 100%. I think one key is don't put it in the dryer, because that'll ruin it. Not that I found that out myself or anything. So the other kind of masks, surgical masks in the hospital, people wear them. Usually we have people wear it for a full shift, and then they get another one for the next day. The N95 masks that are used when we're dealing with patients with COVID, we actually can use them for multiple days in a row, as long as the seal stays correct, and we test for that, as well as as long as they're not visibly soiled or moistures on them. But like a lot of hospitals, we have our own machines, small little machines, almost look like microwaves, but they will heat. They will sterilize the mask. So we do that at the end of the shift, put it in a bag, wait for the next day, and use it again.
I've heard a little bit about sterilizing masks with ultraviolet light, and so can we talk a little bit about that? If someone does not want to put their homemade mask into the dryer, is there something they can? Obviously, you have a clothesline. Does the sunshine or sunlight have any effect on this, or is it have to be more concentrated than simply being out in the sunlight?
That's a good question.
It-
Julie, you want to?
Well, there's only a certain spectrum of UV light that deactivates the virus, but I am not quite so careful with my masks, I'll tell you, and I've been wearing them for months. I do throw mine in the dryer. I happen to be lucky enough to have quite a few of them, and the little cotton ear loop mask, I just throw them in there at the end of the day, and I have other ones to wear, so it's not so stressful. And because I'm so forgetful, I have to have one in my car, and I have to have one at my desk and in various places. But yeah, I don't do anything special. I throw them in there with the other clothes, and I throw them in the dryer, and that's it. But I do know that they will shrink, some of them, so you are right about that. But sometimes that's a good thing.
Dr. Jokela, I want to talk a little bit, anyone else can add onto this. We are now 3 months past our first conversation about this. We've got a chance to see China, who's been dealing with this longer, other Asian countries, and Italy as well. We've got a lot of publicity on this, or a lot of attention. Are we starting to see a second wave in any of those countries? And do you expect to see a second wave of COVID in the coming months?
Thanks, Senator Bennett. It's a tough question, and I think one of the issues when we think about a surge or a wave and all of this is, are we really done with the first wave yet? And I think certainly in the United States here, there's been a lot of talk about that probably we're still in the first wave, and we're seeing a number of bumps, if you will, in this, and no one knows exactly what direction it will all go and how it will pan out. Certainly in China, we've heard recently that there's been an outbreak in Beijing that I think authorities there are working very hard to contain. Could that be a second wave, the beginning of a second wave? I think it's probably too early to say just yet, but I think the fact remains that the virus is out there, and it can, rear its head once we stop wearing masks and stop social distancing. Which is why these behavioral approaches are just so important as we try to get a handle on this before an effective vaccine is available.
I would also say, to follow up on that, Julie Pryde said earlier about the smaller the area of data, the better. When you look at the graph for the United States, it looks like we went up, and we were coming down, and now we're starting to peak up again. Is that a second wave? How do you define that? Really, if you take New York City out of that graph, we are continuing to go up. We really haven't slowed down. So I wouldn't say we're in a second wave. I think we're in the first wave. Will we get more? Yeah, we will get more. Traditionally or historically with pandemics, if they start in the spring, they can sort of quiet down in the summer, but will really peak up again in the fall. That's more with influenza. This is coronavirus, so a little bit different. But I think that it's important to look, and as Julie said, there'll be county-wide data or county data to look at. We can see how our own county is doing, or other counties are doing with this as well.
Yeah, and I think that is what's important to look at, because certainly, you know, we had a big spike in May. Our spikes, we've kept it, you know, pretty kind of steady until we have an outbreak. We had a large outbreak, and then those outbreaks, this is what I think people don't really understand how this works. It goes from person to person to person. So if you just happen to get infected, you're going to maybe infect your household if you're doing all your other measures all the time. But what really happens is you have an outbreak at a job site or something, and if it's large, then those go, or a party or whatever, then those individuals go back into their homes, they infect their household, then they go to their jobs and their household members go to their jobs, and then it just keeps going. And I always liken it to like dropping a pebble in the water, because that's what it feels like to public health. You have that one case and then whoosh. So, and it makes it a lot harder for public health to get on top of it and bring it down. When it's one outbreak at a time, that's certainly a lot easier. And we have a lot of capacity for contact tracing, but like anything, resources are finite, and eventually people can become overwhelmed because, and that's what we've seen in other places, there were so many outbreaks happening at the same time in the same catchment area, if you will, that it overwhelms things. So we don't want to see that happen. Certainly, you know, we're capable of handling like 1 or 2 events where there's an outbreak, but we're moving now from 10 to 50, and that is, for an outbreak, that's orders of magnitude bigger, because again, you're not just talking about those 50 people, you're talking about all the people that they then have in contact before they even know that they are infectious.
I want to go back to something Dr. Healy said a moment ago about taking New York out of the sample. I would imagine you have these conversations with the medical system that you work with. What lessons have we learned from what's happened in New York or other metropolitan areas, and how can we, I guess, take those very negative experiences they saw there and try to make sure that our own systems aren't overwhelmed in Central Illinois?
Well, that's a great question. We haven't been tested like New York was here. If we were, I don't know if we could learn from what happened there, other than we would just try to get through it like they tried to get through it. We know more information about the proper PPE to use, the proper time to wear a mask or a face shield, gowns and gloves. So we learned that from some of the things that happened in New York early. But you know, the bottom line, we only have so many ICU beds in this area, and once those fill up, then we have the potential of having a lot of the things that were scary to look at in New York happening around here. So that's one, you know, it humbles you when you think of it that way. And I'm a human, so I'm the same way. It's nice and sunny out. You want to go outside. We're going to go into phase 4, hooray! But we really got to be careful still.
Can we talk a little bit about where we stand now compared to where we stood 3 months ago, where you know, people talk about ventilator testing. We've talked a lot about we didn't have enough testing, but we didn't have enough PPE, the masks and other protective equipment. We didn't have enough ventilators. Certainly there's only so many ICU beds. What steps have been taken in the last few months to make sure that if there is an increase in our current wave, or perhaps a secondary wave, that we'll be well prepared to deal with that?
Another great question. So we do have more access to PPE now. We had a really great experience, and I think one of the reasons I'm proud to live in this community is our work with the university. Right away, the university heard, you know, what's happening. There's a shortage of vents. There's a shortage of PPE. So we worked real closely, as have others in the community, with the university. Our ability to get testing ramped up quickly was all due to the university being able to give us some equipment and some staff to help in our lab. Since then, we've got our own equipment, our own staff, and the university has that stuff back, so they can do their mega testing soon. We have thousands of vents available because of the university and because of the rapid vent solution that the university came up with. And PPE is available not only from our work with the university, but also just in general. People have ramped up the creation of more PPE. We actually had a meeting this morning at Carle, a group of us talking about the next 3 to 6 months and what happens. And we talked about our supply of PPE and our bed situation. And one thing we're trying to do is have enough PPE stored up for when that next bolus comes of patients.
Thank you. Something that I've heard a lot in the last few months is which population or which segment of population is truly susceptible to this. So certainly the older population, nursing homes are often mentioned as a vulnerable population, but I hear a lot, well, the young people, they're very resistant to it or they're unlikely to get it. Just in the last week, I want to be sensitive to individual cases and their health information, but it was reported that there was a middle-aged individual with no pre-existing conditions, and that has come up in more conversations who passed away, I should say, from COVID. And that has come up more than any other individual case because they surprised a lot of people in my social circles. Can we talk a little bit about that? Are young people at risk? Should they have to wear masks when they go into schools, if schools open up in the fall? Is what we're learning now suggesting that that different age groups are all equally at risk?
I'd be happy to start with that. Yeah, it's an important question. I mean, I think it's clear that we know that there are certain segments of the population which are at higher risk for severe disease, and you mentioned them in terms of people who are older, people with underlying health conditions. We know that persons of color as well have been terribly affected by this. But I think it's also very clear that young people are not immune, and young people can get severely ill, and young people can die, and that's the problem. It has, and even across all these potential risk groups, that there's a sense that it can be somewhat random, and we just don't know for sure who's who may be affected so adversely and who may not be, but absolutely young people can get it and have some really terrible things happen. So, we'd love to be able to say that there's some groups which are immune, but we just can't say that right now.
Yeah, and a lot of the disparities in the morbidity and mortality of this has to do with, of course, what public health looks at all the time, and that is inequities in employment. So a lot of what were called the essential workers at the beginning were really low-wage workers working in places without proper PPE, without access to testing. It's inequities in housing. So individuals go back to overcrowded housing. They might have, multiple families living in the same dwelling. It goes back to inequities in healthcare. At public health, we see people all the time who are, and this is especially true of men, but they have never seen a doctor. They have never been to a healthcare provider. So while you may think you don't have any underlying health conditions, you absolutely could have underlying health conditions. And then we see in the same thing in inequities in access to healthy foods or things like that. So it's definitely impacting people of color, especially younger people of color, more heavily due to a lot of the inequities across the board.
I've heard a lot of press lately about how, sure, Florida's getting really hit in Texas and et cetera, but it's younger people getting infected, almost as if that might be a good thing. And it's, I guess in a way, I think the bottom line, and I'd like to hear others' opinion, I think everyone's probably equally at risk of getting this disease. And some people, especially younger people, teens and 20s, won't know they have it or think they have some allergies, and then others will get really sick. If you're over 65, if you have underlying hypertension, diabetes, lung disease, liver disease, etc., immunocompromised, you're going to know it because you'll be really sick, and those are the people that get hospitalized, and some of them die. So I don't, if the young people all stayed in one area and didn't interact with anyone my age, it would be different, but we all are in the same community. I think, so I guess I want to kind of counter the idea that it's young people getting it now, so that's somehow okay. Someone's going to be affected. They might be affected long term. We don't know that yet because it's only been a few months. So just a few things to mention.
Well, in that vein, recently was on the county public health page, and they do a good job of having real-time statistics, including recovered. How many cases we've had and how many people are considered recovered at this point. What does recovered mean? I hear a lot that people say, oh, it's like this is like the flu. Does recovery mean after a week you're back to a complete normal, or after these last few months, are we seeing that COVID has long-term and more serious effects than what most people consider the flu?
So when you see recovered on our page, all that means is that you'll see active cases. Those are cases that are in isolation that we're still following up with, and they're still infectious. When you see recovered, it means that they are no longer in isolation and that they are considered to be no longer infectious. That does not mean that they're recovered. I mean, we have followed people, and certainly the physicians would know this more than me, but even younger people who have been sick for months. We have had people who report that they're now on oxygen, and certainly we've read plenty of cases of young people who have either died or had amputations. A young woman had a double lung transplant. I mean, so recovered does not mean you just got sick and you're better. It can. It can also mean that you're possibly permanently disabled. So it's literally a spectrum. But when you see that on our page, it just means those people are no longer being followed daily by public health. They're no longer infectious.
There's studies that show that the young people I talked about in their 20s who can get an infection and it's asymptomatic, they don't even know they have an infection, they've done CAT scans of the lungs on those people and there are abnormalities there. So we don't know so recovered might mean you no longer have symptoms, maybe you never had symptoms, but you're 10 days out from your positive test, so we consider you recovered. But we don't know what the long-term damage will be from these things we're seeing in people that have asymptomatic disease.
We've asked Mike a lot of questions about the university, but of course there's a lot of other constituents or people in the area with school-age children. And I have a lot of conversations with superintendents and principals about what school looks like. The State Board of Education recently put out some guidance on these issues. I don't know, a lot of parents are wondering, if they have in-class education, should their kids be expected to wear masks all the time? Is that something that, one, is it something that I think you could expect a kid to do, say a second or third grader, to wear a mask through the whole day? And as long as it's the same class and they're not interacting in a larger group, say a cafeteria, is it safe to take off their mask once they're in the schools if they're around the same group of kids for the whole class or for the whole school year?
I get absolutely inundated with calls about this. The guidance is, and it makes sense, that the kids would wear the masks all the time when they're in school. The reality of it is they may not, for a variety of reasons, but hopefully the majority of them will. There are some people, especially, I would think kids, who won't be able to tolerate it for a variety of reasons. But, that is the plan. The other thing is, I have been in a lot of schools with a lot of kids where when the kids come in, for example, during H1N1, when the kids would come into public health or they go into the doctor to get their flu shot, mine included, one of mine would be throwing a fit and just completely throwing a fit and just acting out and being wild. When we showed up in the schools to do the vaccinations, the kids were just like perfectly fine. They just, lined up and got it. There was no crying, there was no, fit throwing. So I think that if it's an expectation that the kids do it and it's addressed in a way that, and that's what teachers do. They know how to address kids in a way that is age appropriate. So I think that they'll probably do a pretty decent job. I can see why parents would be really anxious about it. I always joke that I couldn't even keep pants on my toddlers and my kindergartners, so keeping a mask on them. But I do think when they get in school, if it's part of the culture in there, and but there will be times where they can be spaced out more, and they are going to be in cohorts, so they will remain. They won't be mixing with as many kids. But it's one of those things where we're going to just have to see, how it's working.
In the same vein, I had a conversation with a day camp here in town where the original call was a concern that the capacity or the limits of how many kids were allowed in each class weren't as high as they were pre-pandemic. But the comment that the individual made was, however, I still don't know what I would do with the kids if I had them, because typically, and I've got 2 little ones, you go to the park, you go to the pool, you go to the playground. Many of those are off limits right now for the kids. So when they do go to school, especially the younger kids, do you expect that the playground equipment, whether it be parks or on school property, will be open? And Dr. Jokela mentioned earlier that we have some new information about whether or not you can transmit the virus through physical objects. Is any of the information we've learned about that changing our minds about whether or not playground equipment or commonly shared toys, sporting equipment is at risk?
That's a good question, and I have not been privy to those conversations on the state level as far as reopening playgrounds and that kind of thing goes. Having said that, I do think with the information we've learned about the virus surviving or not surviving on surfaces is a good thing and informative as far as the decisions that will be made around this issue, and also the fact that they're outside for all the other reasons that we've talked about. So again, I'd be interested in hearing what others may have to say about that too.
Well, we're going to find out here real soon, but the playgrounds are opening. As far as public health is concerned, if the issue with that is we'll never know who's on it. So if we get a positive case and they say that the child had been on this during their infectious period, what we'll have to do is, go to the media and say anyone who was there from this time to this time, please contact public health or to test it. But I'm less concerned about the touching of the surfaces than I am the kids being really close to each other in there and playing for extended period of time. So I think that if parents are out there and they're watching their kids playing on it, they can definitely make sure that the kids don't get on it if there are too many kids on it, if it's too crowded, and then, when they're done playing, go wash their hands. But it's not so much that they're going to just get it on their hands and get infected. It's that kids are often very more actively picking their noses and rubbing their eyeballs and doing things like that, picking other children's noses. So it's that kind of thing that's more concerning necessarily than just touching the equipment.
This is for anyone, I suppose, but for those with small children and they're trying to find something to do with the children throughout the summer, at least till school starts, I've had a lot of questions about when is it safe to let other young children come and play with your child or spend the night or have people come into your house? Is that something that right now would be considered safe? Or would you at least recommend the precautions you mentioned with the mask and the hand washing?
I'd still recommend the precautions that we were talking about, so the social distancing and the hand washing and the mask.
I'd also recommend the idea of cohorting. So if some kids are going to be over with my house with my kids, say, and then each of those kids goes to somebody else's house, that raises the risk for everybody. It case one of them gets sick. So maybe just a small group of people sticking together would be better.
We've touched quite a bit on contact tracing, and I understand that must be very difficult. First of all, can someone explain what that is, and then what steps we've taken to try to do that here in our region and county?
Sure. Contact tracing is an old public health tool, and we do it at public health every single time there's any type of reportable disease. So whether that's a foodborne outbreak, an STD, meningitis, measles, mumps, anything like that, any reportable disease requires us to do an investigation, and then there's actions to take. With COVID, what happens is we get it's a reportable disease, so the lab sends us the positive test results with the information on it, and then we reach out, our case investigators reach out to that individual. We talk to them, we work back through a questionnaire trying to work backwards and find out who they have had close contact with during that infectious period. So we have little tricks to help jog their memory, say, look back in your phone, or look back in your feed, and where were you at this time, and did you have it, we kind of walk through each day and try to figure out any close contact. Obvious close contacts are going to be your household, so whoever you're living with is going to be a close contact, unless you were really specifically trying to stay away from them. Then we go to where do you work, what do you do at your job, and we go through all those type of things, and then the next part is that information goes to contact tracers, and the contact tracers then reach out to all of those contacts. So for every person, there's usually a wide range of contacts. So that the case or the positive person is put into isolation. And when we say put into isolation, that sounds dramatic. It basically means don't leave your house. Stay away from other people, don't leave your house, that's what that means. And then for the others, they're quarantined, which is the same thing, don't leave your house. But then we try to get them tested as well. And then if, hopefully a lot of them are not positive, but if they are, then we start that process over again with that person and do the same thing. So it requires a lot of staff time, and it requires to really do it well. And you need a lot of people, and you need fast data or fast results. And we're very lucky in Champaign County, again, because of the U of I and Carle's lab. We do have fast test results. We don't have to wait 4, 5, 6 days to get results back, because that defeats the entire purpose of it. So we do that, and that's pretty much how we shut down any outbreak.
All right. Michelle, do we have any questions from our Facebook Live that we should address?
If sufficient N95 masks were available, why shouldn't everyone use these rather than the less effective cloth and surgical masks?
Just to repeat that question, it's if the N95 masks are insufficient, they're available to all, why shouldn't people use that in lieu of the homemade masks?
I'll start. I think the point I made about needing to make sure it fits correctly and that it actually works on you. It's not like the surgical mask or the cloth mask where you put it on and you're just blocking things from your mouth and nose from coming out or from coming in. With the N95, it has to have a pretty much perfect seal around your face, and it's just hard to do that without getting a proper test. Now, if everyone had N95, or if there was enough N95s for everyone in the world to have one every day, and everyone got tested, I still don't know if it would really be that much more added protection than what we're already recommending.
And what I want to say about the N95 that I think people don't realize, first of all, I see people wearing them when they do get a hold of them. They're wearing them completely wrong anyway. It's no better than a cloth mask if you don't have, like you said, the seal. And in order to do that, you have to have fit testing, and it's just, multiple steps involved in that. And then the other thing is, they're very difficult. They're respirators. They're very difficult to breathe through. I, for example, have asthma. I cannot spend a lot of time in the N95 mask. And so anyone that has asthma or COPD or a bunch of other things, when you do the questionnaire, when you're first getting fit tested for it, then you have to go to a pulmonologist, I believe, and then they, I don't remember how it happened, it was so long ago, but basically they're telling you if you're getting enough, if you're okay to wear it. So, and I was actually not okay to wear it, which surprised me, but they're just not that easy to do. And talk about difficult, you can't have facial hair, you can't have, which the longer quarantine goes, the more facial hair I have. But that's a completely different thing. So, I mean, they're not as easy to wear. That's why medical professionals wear them, and there's a lot going on behind the scenes. They just don't pick one up and slap it on their face.
And then just one more point to add to that too, even in the hospital, in the medical settings, as Dr. Healy mentioned earlier, the N95s are being reused and sterilized and reused again. There aren't enough N95s around now to use in the way we used to, say, before COVID. You wear it once, you throw it away, and when you go to the next patient who needs one, you'd wear one then. So there's there remains a huge shortage, not only nationally, but even worldwide for N95s, even for healthcare professionals. So we're a long ways off for N95s for everybody else.
And I know we touched on it a little bit earlier, but the nature of Facebook Live is we have viewers that come and go. So for those that aren't lucky enough to have a mom like me that makes her own masks for the family, and if you're going to buy masks that are now getting more and more available on retail establishments, what should we be looking for? What kind of mask? Is there any specific thing we should be looking at? I see some that have little portholes that seem to have more ventilation. Is that more or less safe? Or are we just looking for anything, a scarf, anything that blocks any kind of projectiles?
I'll start, and I'm happy to have colleagues chime in again too. So the masks that are out there that people may be able to purchase that have what look like a little ventilation valve on them, do not buy those, run away from those. They don't help you, they don't protect anyone else either. They are just not worth whatever someone may be paying for them. So first off, just don't buy those. Those aren't, you don't want those. And neither does your neighbor. We're really fortunate to live in a community where there are people like Senator Bennett's mother and many, many others who are making masks hand over fist and, and distributing those widely, not only to Carle and the hospitals, but throughout the community. So there are a lot of cloth face masks for people to wear. Having said that, there are instructions on the CDC's website in terms of how to make it, in terms of how many layers and how big and all that sort of thing. So it's all there, it's all very explicit and all very clear.
Yeah, and I have to say too, I was unbelievably impressed with our community and the amount of people. We had a mask drive, Carle had a mask drive, people were just making them so creative, and I was lucky enough to have a little kid in our lobby that came in for a dental, and somebody had made a bunch of children-sized masks, and they were adorable, and I was able to give him a little Paw Patrol face mask, and I'm telling you, I have never seen a kid light up like that. So, he had on the little paper mask that we have at the front of our lobby, and he got that, and he was very excited. So, I think part of it is just that if kids see other kids are doing it and stuff, and they have cute ones, or they have, something, I think they'll wear them.
I think the bottom line with masks is, I agree 100% with what Dr. Jokela said about with the valve, because if you think about it, a cloth mask or a bandana or whatever you're using, this is getting a little gross, but if you're kind of spit's coming out of your mouth, that's what you're protecting someone from. You're blocking that from coming out of your mouth. If you have a mask with that valve, that spit's coming right out. So.
A good thing to do, and I always use the same example and have for years and years, but Go outside when it's cold and talk, and you see the plume, that is your breath. We don't see it normally, it's always coming out. So you see that, that's your breath. Feel free to put one of those masks on and you'll see it coming out of that little hole that he's talking about, that little port. And the other thing is, next time you're out and it's cold, cough, and then yell, and then sing, and you will see the difference of the amount and how far your breath goes than just normally talking. But it does come out pretty far in general just when you speak. We just don't see it.
Well, I'm glad we asked that question. I think I have a couple of masks with the portholes in my cart on a couple of my pages, so I'm glad I didn't buy those. Michelle, you have some more questions?
Yes. Is there any guidance for medical professionals who are being exposed to COVID through their work, and how they should manage their exposure to others?
Okay, I think I have questions for Dr. Healy, but the question was, and just to repeat that for the microphone, is there any guidance for medical professionals and how they're interacting with their families as well as, of course, at work?
Yeah, luckily at Carle, I mean, we're all worried about that. We all still worry about it. But the data shows that very few of our employees have gotten infected. It's only certainly less than 50, even lower. And the reason is because when we're at work, we're wearing the appropriate protective equipment, the appropriate masks or other things. We still worry about going home and bringing it to our family and our kids, but luckily we haven't seen evidence that that's happening. So that's one thing. One answer is the data shows that we probably are worrying too much, but that's okay because they're our loved ones. We don't want to get them, infected. At Carle, like other places, in the beginning, we secured some hotel rooms in the community because if someone was at work and they didn't feel like they could go home, then we would have them stay in the hotel. Very, very few people did that. Most people go home. Some people stay separate at home. They'll stay in their room. They want to interact with their family. They'll eat separately, use separate utensils. I'm sure some people are still doing that, but we've gotten more comfortable as time has gone on. As long as we're doing the right thing at work, we're protecting our community as well.
What can CU citizens and local healthcare workers expect and handle when 40,000 students come into town?
I think that question is for, I'm not going to just blame it on Mike. Anybody can answer that, but what can our community expect when we have 40,000, I assume, University of Illinois students come back into town?
Well, we're taking, I think as Julia mentioned earlier, a multi-layered approach in working with our students. First of all, it's education, significant amount of education about what they should be doing, what the expectations are. So that's wearing masks, that's social distancing, that's testing, and that's, using that Rockwire app to be able to determine any type of exposure and then how we can follow up. We are going to supplement CUPHD with tracers or the folks that can help. So we have that many more students coming into the community. The manual trace, what do you call them, the tracers that will go out and follow any type of people we're adding to that. And we're going to, like I said, we're going to be doing a significant amount of testing. By the time the students come back, our goal is to have 15 to 20 sites on campus set up to test the students. So our scientists are working on various algorithms to determine how many people should be tested and when they come back based on what their interactions are and what they're doing. But certainly we're going to need the community to help us, bar owners, restaurant owners, to enforce those layered approaches when the students are out engaging.
This is a follow-up question to that one. Is the university worried about student behavior outside of campus spaces like dorms and apartments or houses?
Question was, is the university concerned with outside activities that might happen from the students?
So not only are we working obviously within our residence halls, but we're working with our what we call private certified housing units, so fraternities and sororities. Our university life team, which is one of the 7 teams I mentioned, is going to be working with local landlords and how they can go about helping support us in these efforts.
Okay, so I've asked all the questions that I had in advance, but it really comes down to this. We're at phase 4. The only phase after that is phase 5, which comes post-vaccine. So to the panel, when is that? When are we expecting a vaccine, and what steps are we seeing worldwide that should give us any encouragement about that?
There's a lot of work being done on vaccines right now all over the world. In fact, I was reading something today that said there are 130 different prototypes of vaccines in various stages of development. So exactly when the effective, widely available, low-cost vaccine will be, available for all of us, it's hard to say, of course. I know Dr. Fauci mentioned something just the other day, earlier this week, when he testified before Congress, talking about perhaps there may be something available, if it's not later on, late this year in trials, and or perhaps further along late this year or early next year at some point. So again, if that does come to pass, it's an incredibly fast course for vaccine development, and we'll just have to see how this all goes. But hopefully sometime in the not too distant future, we'll see.
One thing to mention is that we do have a vaccine, and it's called the flu vaccine.
I was just going to say
And you
that.
have to get your flu vaccine. Everyone's going to agree with this. Have to get your flu vaccine this fall. Please get your flu vaccine. We're going to be overwhelmed at Carle, as is everyone else in the community, with people who are sick. And if you have the flu or you have COVID, it looks pretty similar in the beginning. So let's take that flu part out as much as we can by getting your flu vaccine.
All right, and I would just point out, he said at the beginning, so for those that will be contacting my office to tell me that Dr. Bob Healy said that it's the same as the flu, that was not what I heard sitting next to him, but nonetheless. Well, with that, I really appreciate those that have joined us tonight. If you came in at the end, we are going to record this. We have recorded this entire event. It will be available on YouTube and also our social media. But I hope we won't have to have another follow-up to this, but I have enjoyed kind of the bookend approach of many of the same panelists telling us why this phase is different, and more importantly, telling us what we've learned in the last 3 months. So with that, I want to thank everyone who joined us at home, and certainly I want to thank Mike DeLorenzo with the University of Illinois, Dr. Robert Healy with Carle, Dr. Janet Jokela with the University of Illinois College of Medicine, and Julie Pryde with local public health. Thank you everyone for joining us tonight.